Hi, everyone. We're going to go ahead and get this session started. Welcome. My name is Shauna. We are actually pleased to be presenting this session titled The Chronic and Complex Wounded Patient Care Continuum. Now, let me introduce our speaker. This is Cayleigh Minter. She is a Central Pennsylvania native and is currently working at UPMC Wound and Hyperbaric Centers as a nurse practitioner and is an assistant professor and graduate coordinator at Millersville University. After receiving her BSN from York College in 2008, she pursued her love of emergency medicine and completed her master's in nurse practitioner from Millersville University in 2014. Her experience as an NP has taken her from emergency medicine to workers' compensation and employee health to wound and hyperbaric medicine, where she later obtained her doctorate in nursing practice in 2020 and her certified wound care nurse, advanced practice certification. Her current project and investigations specialize on the intercollaborative nature and caring for the complex and chronic wounded patients across the inpatient and outpatient care continuum. Cayleigh?
Hi, guys. Thanks for having me. So I was a little bit nervous, and my family told me to start with a joke. So WOCNs walk into a bar. Just kidding. Okay, so you don't have time to drink. All right, so this evening, I'm really happy to be here. I thank you for letting me be a part of the breakout rooms. I am a nurse practitioner at the UPMC Central PA, Carlisle, Harrisburg, and Mechanicsburg Wound Centers. I'm actually presenting this QI project on behalf of our team. They're incredibly intelligent and skillful nurses, case managers, social workers, administrators, among others, and they also make up about half of this audience. So yay, go team. All right, so this is a quality improvement project that we implemented in Central PA. It's called the Chronic and Complex Wounded Patient Care Continuum. It's an interprofessional rounding implementation that we started to improve our patient care outcomes. So, Michelle, Melissa, Heaven, Amy, Angela, Andrea, Luann, Morgan, Shauna, Danielle, Andrea, Kristen, Kathy, and Bill, thank you. This is our project. Okay, I've outlined 3 objectives for you, and as you can see them on the slide, but our objectives are going to surround the concept of interprofessional collaboration and how that is defined. How can one use interprofessional teams to direct patient outcomes in the wounded patient population? And perhaps we can also identify ways that a similar practice or process could be implemented in other medical specialties from an inpatient to outpatient perspective throughout the healthcare field, really. And yes, I have paper. That's the professor in me. Sorry. Okay. There's a few definitions that we need to be mindful of as we move through the presentation. So a chronic wound on our definition is going to be one that's 30 days old despite wound care and therapy. This can be on admission or prior to or sustained during hospitalization. A complex wound, this is a patient with multiple comorbid conditions and or social complicated determinants of health. This can also include etiologies that are wild, poor response to therapy, or complications. Inpatient, as we're going to define it for our project, is defined as a level of care requiring 24-hour acute care nursing in a hospital setting. This typically requires at least 1 overnight stay. For the purpose of this project, we're calling IDR our interdisciplinary rounds a collaboration among the interdisciplinary team. It's a platform that we are going to develop to integrate patient care plans across the inpatient to outpatient range throughout all teams that participate in that patient's care. Home health, that's a broad term. So in this setting, we're going to call it skilled nursing that is delivered in the home care setting. And in our area in Central PA, this is like mostly private groups. They all kind of cover different geographical zones, but we also have different home health groups that cover different skill levels. So there's that too. And then finally, our transition of care. Of course, our transition of care is to ensure continuity of care and positive patient outcomes, of course, as you can see there. Please don't confuse this with TOC, which is like transfer of care. And we're going to go into that. That was actually a big takeaway from this project. TOC, or transfer of care, is commonly used with surgical global periods and literally transferring care. Okay, so our setting. Let me kind of put you where we're at. Central PA with our UPMC is 7 inpatient hospitals. It's Community, Harrisburg, West Shore, Carlisle, Lidditz, Hanover, and York. We have 5 outpatient wound centers, and fun fact, the last speaker, Dr. Rogers, is my collaborating attending, and we work together. So we have 5 outpatient wound centers, 1 across the street from Community General in Harrisburg, 1 at the West Shore Hospital, 1 at the Carlisle Hospital, and then 1 across town from the hospital in Hanover, and then 1 in Lidditz. So our interprofessional teams that we used for this project were our inpatient teams. That was our WOCN leader and administrator. She oversees the WOCN teams at each one of the inpatient hospitals, so administration. We had administrators from case management kind of oversee the development and the dissemination of this project, but all the case managers at each hospital inpatient team was included in this, and that's throughout all of our hospitals and region. We also use social work. We also use the CNOs and director of nursing at each site. Our outpatient team looks like attendings. We work with general surgeons, podiatrists in the outpatient wound center. We are actually all registered nurse staffed, and all are majority WTA or CWCN certified. And then we have an administrator at the outpatient wound centers, and she was the one that kind of pushed this project along. And then there's me. I'm the only NP for right now. My second NP colleague is joining me after 4 years to be number 2. So I was the first of my kind, and so I'm really excited. She starts on Monday. All right. So I was put in a really unique situation. From my previous nursing experience, Shauna said, I started in the ER at Harrisburg. I worked there for a bunch of years. I met Dr. Rogers there. I finished school. When I was in the hospital, I worked with social work and case managers. And so just being in a health system for long enough, you kind of learn to know people, right? So when I finally landed in wound center, those relationships, and as those people progress through their nursing career or their careers, they're administrators now. And so it's funny because I was able to pull a lot of relationships together that people in the wound center and the inpatient typically didn't have those relationships. So in I come and I said, how can we put our collaborative minds together to improve patient care? In the wound centers, we did have some inappropriate consults where, yes, in a hospitalist setting, they'll consult the WCNs, right? Come see this patient, please, wound care. But we would get an outpatient attending consultation, and sometimes it's definitely something that was in the scope of practice of our WCN. So that was something that we thought, hey, maybe we can address this. Another thing, too, was poor communication. I'll say it. I think we had poor communication from new patients leaving the hospitals into their transition of care. Sometimes they were calling us for their first appointment. I think that we can facilitate that better for our patients. So there's a couple things. Despite having a highly skilled inpatient team, we were also not working together very well. We were kind of separated or segregated, I would say, from inpatient to outpatient. There wasn't a really whole lot of overlap. There was no tracking of wound-specific data in the hospital. Like, we couldn't just call and ask for, readmissions by this diagnosis. I probably could, but when I did, I didn't get detailed information. So we knew we needed more data. And then we knew that there were readmissions happening related to wounds and complications from wounds. So these are all things that we were kind of working through, trying to see how we can improve. Now that you have an idea of kind of our setting, let's move into the literature where we found evidence that supported our interprofessional collaboration and further our problem. Given this was in the pandemic, we also were motivated to see how we might be able to do this virtually. Also, a little disclaimer, interdisciplinary multidisciplinary or interprofessional. They may all be used interchangeably. They mean the same thing. People from different professions putting their minds together for patient care outcomes. So the literature demonstrated the following. Nationally, chronic and complex wounded patients have about a 20% readmission rate, according to the advisory board reference in 2018, and up to 22% according to the Agency for Healthcare Research and Quality in 2021. Readmission can be related to obvious complications like infection or pain, but readmission can also be due to things like lack of resources once the patient leaves the hospital. That can include, but is not limited to, issues with dressing supplies, cost of supplies and support, ability to change their own dressings or the skill needed to change somebody else's dressings, lack of home health services, poor nutrition, poor management of comorbid condition, among many more variables. We know that approximately 1 or 2% of the U.S. population, I should say 1 to 2% of the population, and 15% of the Medicare beneficiaries have wounds. 1 to 2% of the population, 15% of Medicare beneficiaries have wounds. That's a lot of humans, that's a lot of wounds, and it relates to billions of healthcare dollars. As you can see in the above, the AHRQ does break down readmissions by diagnosis, but some of these can also be attributed to specific wound types like pressure injuries, our favorite, skin conditions, or surgical-related readmissions. This is exactly what we were seeing in our experience, nationally, locally. Thus, we had a really clear perspective of the impact of chronic and complex wounds and subsequently the risk for readmission. After we identified this issue, we conceptualized a target goal and objective for a readmission rate less of that national average, so less than 20%. We wanted to achieve less than 20% readmission rate in our patient population. An interprofessional team was gathered and the information and implementation planning began. And we kind of came up with this concept for virtual rounding specific to chronic and complex wounded patients. Again, with my relationships and pressure from my director, we gathered stakeholders from the different inpatient teams, myself, Shauna, some of the WCNs, Wound Center Administration. And so I'll take part for that part only, getting the team to the table. That's the only part that I'm responsible for, I'll say. The rest is everybody else. So now that we've identified the problem and the need for quality improvement, we needed to develop a solution. How could we align and collaborate our talent and expertise to improve the connection between our hospital patients and our outpatient wound centers to ultimately improve outcomes? Again, we were able to bring all the stakeholders to the table. We were able to get input from each discipline. The inpatient and outpatient team started to work together, and we created a pathway or an algorithm, which I'll share in a minute. These stakeholders, again, included WOCNs, RN care managers, social workers, outpatient wound center staff, and administration. We met weekly via Teams for weeks to ensure the momentum for the completion of the pathway. We wanted to develop it ultimately for the successful outcomes. We also wanted to make sure the pathway was simple. If this is going to be distributed far and wide in the hospital systems and everyone's going to read it, we need to keep it simple, right? So we wanted to incorporate the option to initiate patient consults, have all the information where it needed to be in one place. And during this development phase, we noticed a growing relationship between everyone at that table. And with that, mutual respect was born. And I think that was a big outcome of this. This is important as we worked through our journey to develop the pathway and further ways to work together. Ta-da! This is what we came up with. This is our algorithm. So bear with me. I did break it out smaller for you, but after many hours and additions later together, we were able to build an efficient pathway encompassing each discipline's expertise, input, and role. With all of that, we developed the chronic and complex wounded pathway. I can reiterate that this went through so many revisions, but that was important because each department had a say. Their workflow had to be organized and recognized, and it was manageable and realistic for those inpatient units to use. This is a normal process with QI projects. So we got to go back. We got to make the revisions. So I'm going to go to this first part. It appears very busy. I'm sorry. I'm going to go back a sec. It appears very busy, right? The outer portions there on the left, those are resources for nurses to identify high-risk comorbidities, the definitions that we're going by, and information related to the surgical global period. Again, more on that later. But high risk over there at the side. And then in a later revision, which I just realized today was not on here, we actually added the wound center phone numbers. So it's like a one-stop shop for all the information you need for a chronic or complex wound in the inpatient setting. All right, so now I'll break it out for you. Okay. We, at the dark purple box, as we take a look at the pathway, it first considers if the wound is chronic or complex by our definitions that we went over, or if it was hospital acquired, such as a trauma or pressure injury. If the answer is no to both of these, it's best to present the patient and barriers at our virtual rounding review. The virtual rounding review ended up being a 1-hour dedicated time period. We do it on Thursday mornings on Microsoft Teams. You're welcome to join if you'd like. And we have our interdisciplinary conversation, and we talk about ways to discuss and work through their discharge barrier and or how to work through those chronic or complex wounded patients that are in the hospital. Okay, so this is the second half of this slide. So next, the pathway asks the questions, hey, what were the comorbidities and were they assessed? Were they identified? Good. Were they addressed? Did we do something about it? Not only do we want to assess and identify the comorbidities, but we also need to address them. So this is like a first catch, right? So if we get through, the patient comes to rounds, that's also a question that we ask. So it's kind of like a first catch. Did we kind of identify everything that we need to, approach this patient care? We want to ensure that appropriate consults or actions are taken and that they're in motion to address these issues since they typically require a specialized approach. For example, diabetes, limb ischemia, rheumatological conditions, nutritional deficits, and ambulatory or mobility difficulties. This holistic approach assesses all the aspects of the patient's care, and it assists in developing a mutually agreed upon patient plan before they leave the hospital. Next, the pathway asks if the patient is discharging to home or if they're going to another facility like an LTAC or a SNF or an acute rehab. And if the patient cannot be discharged home, the pathway indicates to discuss the case at rounds. If the patient is transitioning to another facility, it's important that we make sure that the training, the special dressings or equipment is needed at that next level of care and that it's available. If it is anticipated that the patient will discharge home, the WOCN or the care management person based on the algorithm actually notifies and collaborates with each other, and then the attending inpatient physician on the discharge plan. They will also refer the patient to the outpatient wound center, and they'll communicate with an inpatient hospital attending for an inpatient wound consult only if needed. If an outpatient wound center appointment is needed, the WOCN will coordinate and communicate this care with the case management team or the social worker, and will actually schedule the outpatient appointment with the expectation that it'll be within a week post-discharge. And if it's identified that no outpatient center or referral or appointment is needed, the WOCN will continue to collaborate with the care management team to work towards the best discharge plan, and follow-up appointment will be arranged with the managing provider by care management. And that sometimes looks like follow-up with the surgeon or, if they were sent from an office back with that provider. And then when they leave, all those appointments will actually show up on their paperwork with the time, date, and place of the follow-up. So one thing to pull out here that we learned from this process is surgical globals. When a surgeon operates, they are given a 7 or 90-day surgical global depending on the procedure that was performed. Believe it or not, an amputation of a toe is like 7 days. A BK is 90 days. INDs are 0 days. So there's been a learning curve for everyone here. But the fun fact is often surgeons need help healing wounds, right? That's like a large population of the wounds that we take care of. So they'll say, hey, help me heal this wound. Great, I'd love to. But then you have to transfer care. So that means that they will no longer see the patient. So they're no longer being compensated under that global period. they're signing off. And so that's great. Happy to do it if the patient's appropriate for an outpatient wound center, right? So that's been a big learning curve for us. And we're still learning about it. So if the surgeon wishes to transfer care, there's a formal document, and this is super important for billing purposes, so nobody's double dipping. If the surgeon decides not to transfer care, but they still need our help, we just encourage them to pick up the phone, and we at the wound center, and I know all the WCMs are happy to provide our recommendations. This pathway has led a way for the staff to initiate inpatient wound consults as well, for me and my attendings. And I have to say, we'll talk about kind of some of the results later, but it's really kind of caught some of those inappropriate referrals that we were talking about. And finally, for the algorithm, we added our office telephone numbers, like I said, and this was widely then distributed to all the inpatient WCN teams, care management. And when I say care management, I'm meaning the case managers, the social work team, kind of that like discharge planning group, and at all the hospitals. So we finally got the pathway nailed down, approved, disseminated, educated. This pathway was then attempted to be completed before COVID. And so I kind of told you that. But we were able to get everyone together and get it started in the beginning of January 2021. To prepare for the virtual rounding review, I actually send a wound virtual round email roundup. Sometimes I'm funny, sometimes I'm not. And I say, hey guys, let me know if you guys have anybody to discuss this week. Call, of course, if you have anybody before that. And the nice thing about this is this process between those inpatient and outpatient teams really open that communication channel. Not that they were afraid to call before, but like I really feel like we're communicating better. So if they have a patient that they need our assistance, they don't have to wait till Thursday. Like they can just give us a call. We'll discuss anytime. So I send the email, and then that gives me a chance to kind of review those patients in the medical record, prepare an agenda, and we'll discuss. These patients stay on the discussion agenda then until they're formally discharged, and then we can also log that data. Data is recorded for, of course, future reference. In an effort to decrease length of stay, we encourage staff to alert us if any patients needing a review and discussion needs to occur before virtual rounding. And obviously, because of the protected patient information, IRB was definitely obtained. Okay. So I'm going to give you a little bit of feedback from each interprofessional team's perspectives. So this one is care management. Care management, like I said, the team members will actually respond to the email, or if they don't have anybody, they ignore my email. But patients needing urgent requests, they call. Referrals come to us, and it can come to us through several ways, like I said, but what the care management team said from this process, what they learned is to actually do a proactive review of the patient. So like if a patient is wounded, they immediately apply this algorithm to them. But they also have identified proactive scores. They'll use tools like the LACE score, which is a readmission risk score. And if they have a score of 59 or greater, there's also the unplanned readmission score of 15% or greater. So that kind of flags them proactively to bring them to us without even a discharge barrier identified. And we call that putting it on the radar. So maybe we don't need to discuss them now, but they have a high readmission risk score. So we'll keep them on the agenda. We'll talk about them if we need them. We'll intervene if we need them, but at least we are aware of them. Again, those discharge barriers that I talked about, when they're identified, it can be cost, coverage, transportation, ability, supplies, drugs, family dynamics, access, all of the things. So once the patients are identified, it's essential to communicate the key elements of the case for the committee to review and make suggestions, of course. I asked the team to come up, to submit a patient in this manner for clarity, organization, and data collection. The key elements include the patient's name, age, insurance plan, comorbid conditions like diabetes, obesity, hypertension, history of present illness. I want a brief blurb. Tell me what the patient's doing here, what discharge barriers that might exist, their readmission risk, and any resources that may have been attempted or initiated thus far. Other questions do arise from the group based on the information that's presented during rounds. Care management can then investigate further. They're great. They get answers that are needed and respond. And that's like, does this fall under a global? Is it approved? Are we waiting for transportation? Those kinds of things. So they will get back to us if we need them to. And then the one thing about this is we can always ask more questions. So if care management wasn't on the call, if we didn't have that interprofessional team at the table, we wouldn't know that information. So that's another benefit. So we wanted to share an actual case study with you that was referred through our committee and through the process, through the algorithm. And it was related to barriers finding home health for wound vac changes. We do treat discharge home wound vacs pretty seriously. I mean, they're not neutral. They can cause lots of problems. So we want to make sure that they have the appropriate resources at home, that they're safe to have them at home with home health or without. So each case is reviewed on kind of an individual basis. But this patient was a 47-year-old female with uncontrolled diabetes. She was not taking any medications. She presented to our ER with right buttock swelling and drainage. She had just returned from a recent trip from the Dominican Republic 4 days prior. 2 days before that, she had been on a boat in the Dominican and she had stopped in a wooded area and she felt that she had been bitten by an unidentified insect. Since returning and in the presence of uncontrolled diabetes, the site had become increasingly swollen and warm to the touch. She had a decreased appetite, nausea, fever, and fatigue, and lots of pain. She actually met three of the 4 sepsis criteria. She was admitted. She was immediately given IV fluid and started on broad-spectrum IV antibiotics. Her CBC had leukocytosis and with a left shift and lymphocytosis. Her glucose was 373 on admission. And her BHT was elevated. Her diagnosis was gluteal abscess. So her treatment required IND of the abscess, wound vac placement in appropriate time, IV antibiotic therapy, clearly some diabetic education and care. She needed all the resources and all the teaching. Her discharge barriers were identified that she needed her wound vac changes obviously 3 times a week, right? She lives alone. She works, but she's unable to secure home health. And I think the reason for her was geographical location. They just didn't go up there or something like that. Her readmission rate was high based on the calculated scores for her diabetes and the wound. And the resources attempted. Her attempts were 6 in-home care agency referrals were all made and declined for various reasons. In our area, it's really common for home health to decline based on geographical location. Like I said, we're kind of like a real urban area by a lot of suburban and rural, some mountains that people just, rivers that people don't cross, those kinds of things. So geographical location is a big one. Skill set. There's actually nurses, home groups that do different things. Some don't do VACs. Insurance coverage. Everyone's favorite. And staffing is my personal favorite. They don't have staff right now. So that patient was declined, but we still had the need. So we would otherwise keep this patient in the hospital, right? Longer. We would keep her on IV antibiotics probably longer, resistance. We would probably keep her on a VAC for longer, more dollars. And or conversely, right? We'd kick her out. We'd say, here's some oral antibiotics. Good luck. Here's a wet to dry dressing. Here's how you do it. Good luck doing it on your bottom. And she's going to readmit, right? So it's a lose-lose. She was brought up to our table for discussion. And so we talked about it. Despite making the 6 in-network home care referrals and after discussing it with the group, we were able to come up with a solution. Our recommendations included to start to wean from IV antibiotics as the cultures came back. We tried to see if we could squeeze her into my schedule. Yay. We determined, is she safe for a VAC at home? Is she young and mobile? Can she remove it if it malfunctions? And we identified that she was able to through our WOCN, who was able to educate her and manage her in the inpatient settings. And each part of the team members added a piece. Care management. So I said, yeah, we can fit her in at the wound center 3 times a week for nurse visits and provider visits for VAC changes. Case management actually followed up with the patient and her boyfriend to make sure that she actually had the transportation to get to those appointments. Her first appointment was made for February 6th, 2023. The WOCM team was also able to educate the patient on her boyfriend at home, on safe vac use, safety, alarm troubleshooting. And in addition, our WOCM team actually provided the supplies that would be needed at home for an emergency dressing until she was able to get to her first follow-up visit. After securing this plan, we were able to safely discharge her home on February 3rd, 2023. Care management made her a follow-up appointment with endocrinology. They made her an appointment with diabetes education. And most of all, they made her a follow-up appointment with a primary care specialist. So, that was a pretty comprehensive plan going out. We felt pretty good about it. And I was going to see her, a couple times in the office. So what was the outcome? She didn't readmit. Yay. She was seen in the wound center on February 6th, and her wound vac care continued with regular changes and without complications. The wound care team was able to secure a home health agency then after a few days to take over the case starting in February 13th. So then she had the 24-hour coverage of a home nurse that could come out to her. Further, after our initial referral, she was also further referred to nutrition services, and the endocrinology care and the primary care were able to get on about within a week or two for that transition of care out of the hospital visits. So as a result of her virtual round, she got all the appropriate follow-up care for her diabetes and hypertension post-hospitalization. By February 13th, the home care agency, and by February 27th, the home care agency that she had such great improvement that her VAC was actually discontinued because then we were seeing her weekly. So we work closely with home health. And she completely approximated and closed by March 21st. She was discharged from service. And this case really highlights how a multidisciplinary team can use creativity, expertise, favors, collaboration, and we prevent readmissions and prolonged hospitalizations for our complex wounded patients. So a positive. All right. A few more care management perspectives, and then we'll go on to the others. I think I'm still okay on time. All right, cool. This case study was just one example of a barrier that the case management team can encounter to bring the group to discuss. But other things that we discuss all the time are insurance coverage. Do you know how much I've learned about insurance coverage? A non-citizen, Medicaid, in-network, out-of-network, reimbursements, home care agencies. These are all barriers, and even where the patient lives, like we talked about. We also talked about some of these already, but if they just flat out decline the referral home health, the patient might live alone or have no family involvement. We have to sometimes troubleshoot things. Even the location of the wound on the patient can be a barrier. Care management team will also ask patients about transportation, financial status, and always make sure that there's appropriate follow-up before they leave the hospital. As you can see, having the ability to discuss these barriers in a multidisciplinary team is so valuable. Briefly, the inpatient WOCN perspective. Tell me if I'm wrong, you guys, okay? But I think, this is my data, you can go ahead and read it, but whatever. The WOCN perspective, open communication. I think that was really important. I think that we have outstanding support with and rapport with one another. They allow us, and this algorithm actually lets them work, I think, higher to their scope of practice and to their license. It aligns the collaboration better with the care managers within the floors with our WOCN teams. Maybe it helps stratify your patients a little bit more through the algorithm, and it definitely results in increased knowledge sharing. Absolutely. I've learned so much working with these nurses virtually. From the NP perspective, that's a lot of paperwork. That's my perspective, but there's a lot of data analysis too. And I've learned so much from the process, but not limited to wound care secrets, dressing recommendations, like I said, billing. I didn't know that there was differences between LTACs, subacute care, SNFs, assisted living. I didn't know these things. So I learned so much. And finally, criteria and eligibility. And then lastly, our thorn in our side right now, surgical globals. From a wound center perspective, we have a clear heads up about the incoming patients now, which is super nice. We get like a mini report before they even walk in the door. We have a process now to try to expedite that transfer of care to the wound center within that week. And I love that we talk about new products and dressings through our knowledge sharing. So on to the data, yay. If anybody wants to be my SPSS guru, please call me. Okay. So data. Year 1 was evaluated from the period of January 7th, 2021 to January 8th, 2022, because those were Thursdays. After obtaining IRB approval for retrospective analysis, we did identify the following trends and data for year 1. We started with just 3 hospitals participating, but by the end of the year, we had 5 of our 7 on board. 63 total patients were discussed at virtual round, 35 of them being male, 28 of them being female. The patient's age was 51.7 this year, and the average was 24.7 days for length of stay of these patients discussed. That wasn't like general wounded patients in the hospital. That was just the patients that were brought through the algorithm and discussed. We didn't have our own comparison prior to this implementation, so I don't really have a whole lot of comparative data. So we did our national average of 20%, right? That's our goal for this implementation. So year 1 resulted in actually 20 new wound care center referrals to the wound center. Our 30-day readmission rate was average of 9.5, which is awesome, 9.5%. Interestingly, though, when we did the chart review, we also identified that within 7 days of initial discharge, 3 of 6 of them were readmitted. So of the total 6 people that were readmitted within 30 days, half of them were readmitted within 7. So we maybe missed something there, right? Maybe that wasn't such a safe discharge. So that was very interesting. Other themes that were reviewed included a variety of insurances, private insurers, Medicaid, Medicare. Themes revealed different wound etiology, and they kind of go in groups. You guys probably see that in your practice too. This year it really reflected surgical or pressure-related wounds and comorbidities, hypertension, diabetes, and obesity, which correlate well with chronic wounds across the U.S. So we talk about year 2. It varied a little bit. Again, January 9th, 2022 to January 7th, 2023, Thursdays. We discussed 52 patients. We talked about 30 males and 22 females. The average age was a bit older. They were 56.4 years this year. And the average length of stay was 17 days, and this was significantly lower than the previous year of 24 days. We had 19 new wound center referrals. And for readmission, we discussed during virtual rounds, 6 were readmitted again within 30 days for the year, which was based on the amount of patients that we talked about, a slight increase to 11%. But we still were well below our 20% average. Again, themes and interesting pieces, new knowledge was shared, and several pyodermas came through that year, similar cases, and comorbid themes all kind of aligned to the previous year. But this year, we also brought in the rest of the hospitals and the outpatient center RNs as well. So we'll just review year 1 and year 2 together. This is 104 weeks of cumulative data. Obviously some of this is analytical, some of this is anecdotal, but at the end of the first 2 years, 104 weeks, we revealed that our readmission average for those discussed was 10.4%, and we had a total of 40 new referrals. Further, we were able to establish another 27 of previously established outpatient wound care patients back into our wound centers. Upon further review of the readmissions and for the cause analysis, we did notice that 5 of the 12 total readmissions for this 104 weeks were directed to somewhere other than wound centers. And it leaves the question in my mind, if they had that support available, that transition through our centers appropriate to the patient, could we have possibly prevented those readmissions? And I'm not saying that I'm great or amazing or anything, but they did come from the inpatient to outpatient transfer of care through our teams and guiding our process. Could we have avoided 41% of those total 2-year readmissions? Who knows? But I would be curious to see. Year 3. And this is in process. I did present this at our annual wound conference in Pittsburgh in October. So I did this data up until August 2023. We are currently in our 3rd year period, so that's where we're at. And we're continuing to improve our quest to improve the quality and continuity of care in the wounded patient population. So from January 8th to August 17th, 2023. Our analysis resulted in 41 patients discussed, and we ranged from 22 to 84 years old at 6 of 7 hospitals, and that was just because that 7th hospital didn't have anybody to discuss up until that time. In that period, we had 13 new referrals, and that continues to get monitored. Readmission rates have not yet been analyzed. But as we continue to identify this new data and we keep talking, we get asked all the time for new data from different people, different teams, and they say, hey, what do you know about this? So some weeks we have full patient loads to discuss. I have, an hour of wrap up and, case review to do. Some days we have very few, so we'll share like a case or a new drug or something like that. Regardless, there are always new questions that arise, and we are always asked for that data. And we aspire to identify new themes in our what we're doing. So most recently, we were asked to see how many of our virtual rounding patients directly met a discharge barrier related to home health. That was the reason they couldn't leave the hospital. And what was our outcome? So we reviewed the data. The top chart actually reflects the geographical location of all the patients discussed. And the bottom chart reflected total patients with readmission numbers included. So the numbers are a little different. We identified the top chart that there were 17 cases that met home health barriers in 2021. Was that related to COVID? Was that related to staffing? We're not sure. 7 in 2022 and 7 thus far in 2023. And largely what we identified here was geographical location, out of area. We have to consider that as a discharge barrier, having coverage or jurisdiction over that geographical area for home health, or the length of, their drive or commute to the wound centers. And I think that is that slide. Okay, wrapping it up here. So ultimately, in reviewing the data, we saw a decreased length of stay to readmissions related to our wounds. Our teams were able to recognize and identify patients with wounds as an area of concern. There was earlier identification, and we continued that continuum post-discharge. Also, beyond the healthcare agencies, the home healthcare agencies, we identified other resources available to us that none of us knew about. We identified other outpatient clinics that can do wound care. We identified that our street medicine team was more than happy to support home health visits with wound care. Street medicine is taking medicine to the unhoused populations. We have a really cool program. Video visits, like we could use video medicines with a paramedicine or a paramedic in the home. That was available to us. So we really started to really bridge gaps in the care. And we only did that through the knowledge sharing and collaboration. We were able to identify and clarify patients that fell into that surgical global period. We offered wound care training to the surgical offices, actually, and we managed, several surgical transfers to the wound care center as well. We had successes such as closed loop communication and accountability. It played an important role in the effectiveness of this pathway. This process has been promoted and supported by our hospital executives. We're proud to say that. All of our hospitals are on board. Everyone utilizes it. It's a collaboration and thinking outside the box, but it's proven in our little data review that we have successful outcomes. So a brief business perspective, right? I gave you all the different perspectives. From a brief business perspective, this is a low cost and high yield outcome. Short time commitment, low cost. Our meetings typically range from about 15 to 30 minutes, even though we started with designating an hour. It doesn't really detract us from responsibilities. And if the WCNs are up into their eyeballs with consults, it's okay that they miss, they'll get on next week, or they'll have somebody designate a representative for them. Each week, I encourage the team members to reach out to myself if they need anything. We've obviously identified new referrals to the wound care centers. That's money in, right? And reestablishing previous patients, so that's always positive. We're also reducing our readmissions and length of stay comparative to year, and that's healthcare dollars saved in the patients that we participate care in. All right, I think I have 2 more slides and I'll be done. As a team, we've had several unintentional outcomes. Our data is now being used to support other initiatives, like I said. We've had a discussion with the Epic team. We have Epic, the EMR. I said, please, oh please, can we get a button for this? So I would love to just, download a report. That'd be super cool. So that's a wish list. They said, yeah, we'll get to it. Number 3, we noticed informal themes. We identified that the surgical service wasn't actually identifying, they would just say call for an appointment post-discharge for their surgical patients. And we were like, no. So we actually, our care management is actually going back, making those appointments before the patient leaves. We include pacer pockets now. That was a new addition this year, hot off the press. So unfortunately, they're under a surgical global. So we're collaboratively kind of like, hey, did you think about do this dressing? And the WCNs are handling that beautifully. We're now sharing knowledge, tips, and tricks, case presentations. For example, the inpatient team recently has seen a lot of success with a specific wound cleaner, and so we're trialing it in the outpatient setting. Wouldn't have known about that unless they were sharing their knowledge. And then finally, mutual respect. Like I said, this is a hallmark concept of this project. It's a highlight for me. We've brought many teams and expertises together, and it's just amazing that we're so willing to work together. In review of our inpatient and outpatient teams, again, it was just on Microsoft Teams for 15 minutes. So this is my wrap-up slide. Our sustainability plan continues. We're rounding out our third year with no end in sight. It's truly applicable to any specialty, and it helped us, identify inappropriate discharges or referrals. Why not utilize this in endocrine? Why not utilize this in the CHF specialty or other subspecialties? I think it's applicable. We're continuing. How can we expand this? What's next? I think we're going to do ostomy patients. I think there's definitely room that we can support these patients better. A collaborative process now, we can do that. Finally, we're excited to be working with the Wolf Center out in Pittsburgh. Hopefully that can help us disseminate our information even further across the United States. And then I just want to say I'm grateful to be having the opportunity to share our project with you today. Our virtual wound care process. Hope you gained a new perspective and that you'll consider making a similar initiative in your respective field. It is applicable, and I hope that it continues to benefit everybody. Thank you for your time today. Questions?
Wonderful presentation.
Thank you.
But thank you. Wonderful presentation. Quite a bit to unpack.
Yeah.
It's obvious you have a great relationship, inpatient versus outpatient wound center, where they don't mind nurse visits. Your length of stay, that seemed kind of long to me. 24 days?
I think for the first year, we had some outliers. I think we had some long haul patients, and that was also 2021. So we were still boarding patients quite long due to outpatient status and COVID. So I do think that was related to outliers.
Yeah. Well, it looked like you decreased by about 40%.
Yeah.
Second year.
Yeah.
What was the other thing? Patients who were readmitted, not coming from the wound center, what would be your strategy to get them to the wound center? Do they just show up at the ER? Do the primary send them to you?
Yeah, they can come to us for a variety of reasons, either through elective surgeries, they can come in through direct admits, or they could come through the ER. Our WCN staff, based on the algorithm, is not afraid to say now, hey, did you consider a wound care center referral? Because maybe it was a resource that provider who sent the patient or is managing the patient wasn't aware of. So just making them aware of the resources that exist. And the WCNs aren't afraid to say that.
Agreed. Because as a specialty, wound care, it's still unbelievable what a secret it is.
I know. What the heck?
And I think there was one other thing. IRB, could you explain that, please?
Yeah, so an institutional review board, those are the people that say, yes, you are a designated researcher, you're going to keep patient information protected. So if you ever do a quality initiative like that and you want to look at patient identifiers, which we needed to, right, to look at these patients retroactively or retrospectively, you have to get IRB approval to be able to do that. Sometimes QI initiatives are what they call exempt from full IRB review. And I think that's what this was, because we're not going back to intervene on the patients at all. It's just more of a data review of what our action was. So it got IRB approval, and you need that for publication, which is hopefully the next step.
And lastly, the 90-day global.
Yeah, surgical globals.
A wound care center background.
Yes.
It's usually not a problem getting the surgeons to sign that over.
Sometimes I've had really, I feel like overwhelming, acutely surgical patients that come into my office and I'm like looking at bowel and I'm like, oh my gosh, they're in a wound center, right? So there's that. But then there's the ones that, and they're quick to turn over. Then there's the ones like, I'm just going to use an example, ortho. They're so owner. That's my knee. Don't touch my knee. It's mine. And so we actually see like the full gamut. But what was happening is like surgeons would be like, hey, Cayleigh, Dr. Rogers, can you help me with this wound? And we'd say, sure, bring him over. And then we were billing for a visit under that global period, which we're not going to get paid for now because, or we're double dipping. And so it was like, So we actually stopped immediately. And we have really done a really good review of our surgical global. So we're billing appropriately.
Well, with time, hopefully that trust, or they won't be so.
Yes, definitely.
Their joints or whatever.
Yeah, exactly.
Thank you very much.
Yeah, thanks.
Thanks. That was great. Thank you. Kind of going down the same path as that question, I don't know if it's an extenuating circumstance, but within that 90-day global, I do work in the wound center as an APN, but I'm also infectious disease. So I work privately in a hospital, in a wound center, and I follow our patients that we see in the hospital. They come to me usually within a week. A lot of them discharge on IV antibiotics or orals or something. It's discharge, follow cultures, make the changes. And a lot of them are surgical and ortho and podiatry and vascular. And we are seeing them during that time.
Right.
So is it double dipping?
I don't think so. So I think typically you're starting that IV antibiotic therapy planning before surgery, or it's a result of a surgery. So I think that is considered treatment, as where, and I'm not an expert. Full disclosure. But I think it has to be like the surgeon opens, creates the wound. It's their wound. I think it's specifically related to the intervention, not the adjunctive therapy. Right. So I think you're good.
I agree.
Yeah.
They're opening, creating that wound. We may be discharging them on the antibiotics, but then they leave with a wound and the antibiotics, and then they come to see me, and I'm managing all of it.
Yeah, I would talk to your billing office and make sure they're not billing under that same surgical code because of that global period. Just, again, so far outside my scope, but it was brought to my attention. And so that's something that we just, now it's a conversation with the surgeon and a piece of paper.
Who was that brought to your attention by? Like which interdisciplinary
our administrator, Stephanie.
Administrator in the wound center.
Yes.
Who does like all your billing and everything?
And she oversees it for sure.
Yeah. Interesting.
Yeah. So something we learned. I've still been doing it.
I'm like sweating.
I know. You're fine.
The cases are just like out of control. They're wonderful and they're great. They're great cases to manage because we really are. I mean, I'm taking ownership of them.
Right.
For sure.
Right.
But
then you should have that transfer of care. Then you're getting paid for it.
Yeah.
Yep.
Yeah. We'll have to find out.
Good luck.
Thank you so much. This was really a great talk.
Thanks.
This is something that I'm trying to, when I started at the center that I'm at right now, it's in we're in a pretty siloed medical system. So some people don't even know that we're there. WOCs that are inpatient do know we're there and don't really refer. So can you tell me a little bit about the buy-in from the in-house WOCs, case management, physicians, etc.?
So I'm going to give you two perspectives. One is I worked with Dr. Rogers in 2006 in the ER. I worked with Shauna. I think she taught me how to draw blood back in 2006, to be honest with you. I worked with Jen Orth, who's now the administrator of case management as an ER nurse. I worked with Jen Shuey as a case manager when I was afloat. I had a lot of HR perspective from my workers' comp role, which was huge, I think, on this as well. But I had these relationships with everyone. And when my boss said, hey, I want this to happen, I just texted them. I was just like, hey, friends, long time no see, let's talk. And so we made it happen. But in the alternative where you know, there might be those behaviors, there might be those relationships. we need to do what's best for the patient. I would invite everybody to an education session and tell them what you offer. Tell them how you might be able to benefit them so you get their buy-in. Hey, I think that I can get your transfer of care into our office within a week. I don't know if that's realistic, but like maybe you can say, I want to do this initiative and measure it. This is what I can do for you. And I think it's like I said, it's a win for everyone. So I think that's one way to go about it, make it a positive spin. But you do have to reach out. I would also try to get an administrator buy-in too. Be like, this is what I want to do. I want to measure it.
Yeah. So we do have some administrative in our on our campus. We do have the administrative buy-in, and they've actually kind of gotten the main campus to kind of say, hey, it's board chairs.
Sure.
Come on over here.
The feelings.
It's starting to happen.
There's so many feelings. That's the problem. It's feelings. So we just got to overcome them. Yeah, for sure.
Thank you so much.
Of course. Any other questions?
How do you handle your readmissions to a different hospital? You're in a close vicinity to 2 other facilities that are not part of your system. We do get your patients.
Yeah, I don't know about them. Unless somebody calls, they're established in the wound center. That's the only way I would know about it. All right, I think I'm out of time, guys. Thank you so much.